guess we will get started, and I will send a note. All right, so if you have a question that comes up for you as we're going along, please place it in the chat. And after we've done all the posters, we will go through the questions in the chat, and you will also be welcome to unmute yourself and ask a question at that point. All right, so we will turn it over to our first poster presenter.
Hello, everyone. Can you see my screen okay? Perfect. I'll just go ahead then. Hello, my name is Mariesa. I am a junior research associate at Kooth Digital Health. Before I start, I just want to thank you for your interest in this track and to disclose that all authors are employees at Kooth. The process evaluation I want to share with you today relates to an innovative partnership between Kooth Digital Health and the NHS Youth Mental Health Services in Suffolk, UK. This partnership aims to address the growing pressures on NHS Youth Mental Health Services, which reached an all-time high in recent years, leaving many young people on long waitlists and without timely support. Kooth's integrated digital pathway was introduced to provide rapid, accessible mental health support for young people awaiting care from NHS services. And the pathway includes a welcome call, 6 structured one-to-one, text-based chat sessions with a practitioner, access to peer support, self-help tools, and crisis and safeguarding supports. So far, we've had 155 referrals, 90% of which were deemed suitable for the pathway. Of those, 56% engaged with the service, with half having completed the full intervention. Most importantly, 34% of those who completed the intervention did not need further support from NHS Youth Mental Health Services, and this demonstrates the intervention's potential to reduce system pressure while supporting young people effectively. We recognize that there are still areas for improvement. However, this pilot has made one thing clear, and that is that digital services can alleviate pressure of overburdened mental health services, and that is a great success. Thank you, and I'm happy to take questions at the end.
Great, thank you. All right, presenter number 2.
Can you see my screen? Okay, thank you. So, hello, my name is Paz, and I'm from the Hebrew University of Jerusalem. And I'm really happy to present my work that has been done in collaboration with Eleos Health, and which is actually part of a bigger project in which we developed a framework for pre-processing large data sets of transcripts from behavioral treatment sessions. And so why do this? So the rise in AI technology make it easy to collect conversational data and specifically therapy sessions through recording and transcribing. And of course, we as researchers, we see the big promise in analyzing these transcripts. However, in large-scale recording, we face the challenge of unintended recordings. Though this can be peer consultation, just all-way conversations, anything that get in the recorder accidentally, and we don't want it in our dataset. So our goal was to help researchers to automatically filter these datasets and distinguish what is a genuine therapeutic conversation from other types of interactions. And we did it using large language models. So we created a specialized prompt that defines the core characteristics, what we see as the core characteristics that indicate that a conversation is actually a therapy session. And to validate our model's performance, we assembled a dataset of 51 transcripts, and these were independently classified by 2 human raters. One of them was a training psychologist. So as you can tell from the right side of the screen in the results, we achieved what we consider to be strong inter-rater reliability. Cons kappa was 0.71. And interestingly, disagreements between the human raters primarily involved identifying the session type, whether it was individual, couple, or family therapy, but not whether therapy occurred at all. Okay, sorry, I'll finish. When comparing to LLM to human raters, so there were also 9 disagreements, but mainly the model did a good job. So we demonstrated that zero-shot prompting can reliably distinguish therapeutic sessions from non-sessions, achieving high agreement with human coders. And perhaps most interesting, and with this I will finish, that LLM-generated summaries were also able to capture the dynamics and the roles of the speakers beyond what was given in the speaker labels. So thank you very much.
Terrific, thank you. We will move on to poster number 3. Is Keke here? I saw, oh yeah, there.
Should I just grab the screen?
Yep, go ahead and share your screen.
Okay. Hi, everyone. Today I'm going to talk about some of the results we have for our effort to expand precision behavioral health, which is a digital-first healthcare model into primary care settings. The idea is to really help empower and help our primary care physicians to connect patients with behavioral health concerns to a variety of digital tools. So we started this work in October 2023, and we used user-centered design strategy to help our expansion. And I think there are 2 key results I want to highlight. So far, we see over 4,000 patients that have been referred to a variety of digital tools through the PBH program via primary care from the day we launched until earlier this month. And in terms of, we also collect patient reported outcome. So we took a look at the clinical improvement from those patients that's being referred by the primary care. And we do see a significant clinical improvement from the patients who are using the digital tools. So the bottom line I think I want to highlight is once primary care providers, when they have the resources or their trainings and they feel comfortable, they are able to refer patients with behavioral health concerns to digital interventions. And also for patients who are referred to digital tools, we see high acceptance rates and we see good clinical improvement. Thank you.
Terrific, thank you. All right, we will move on to poster number 4. Don't forget to, if questions come up for you as we go along that you would like to loop back to at the end, please put them in the chat as we go along. I will turn it over to presenter 4.
Hi, everyone. Hopefully you can see my screen. Today I'm going to be talking about our work on using gamification to assess psychosis spectrum symptoms and their risk. And what we focused on was developing games that try to tease out these suspiciousness and delusions that people experience during psychosis with having naturalistic type scenarios that they follow tasks in. And so we designed two tasks. First task was this one called the Jungle Treasure Hunt task, where a person is going through a maze and they have to choose between left or right. The advisor's intent is unknown to them, and sometimes the advisor is going to give them bad advice. And they're supposed to know when to follow the advice and when not to follow the advice. And they get penalized if they do get it wrong, and then the win point if they get it right. And then the second one is supposed to assess their jump into conclusion biases. And in this case, the environment stays the same, and they're asked the question multiple times over and over again to judge the instability of their beliefs. And to analyze this, we used a hierarchical Gaussian filter, which is basically based on the premise that a person updates their beliefs based on the errors in what happened before. And so we use different types of filters for this. And we deployed these games with 237 users on Prolific over the span of 2 weeks. So they played it at the first time point. And they also responded to the hierarchical taxonomy of psychopathology questionnaires. And we focused on the subgroup around suspiciousness, delusions, and hallucinations to kind of see how their response is correlated with the performance in the games. Before going ahead to run deeper analysis on that, we wanted to make sure that the games that we built had good test-retest reliability. So to ensure that the markers that we found can work across different contexts and we're not just predicting the wrong things from them. And we did find some good reliable markers in between them, mostly the ones that were continuous. So how much they wagered or the advice taken ratios or how confident they were in certain points. And from that reliability standpoint, we also looked at how well the high top measures were, and they were also reliable. And from there, next thing we looked at was if there were any practice effects. So if people were just behaving better because of, what they've learned from the task, or if this were actually like good measures. And finally, what we then did was look at the relationship in terms of linear modeling between the game performance. And what we found was that the first game that probed people's decision making on like going through the jungle, we found that people with lower performance accuracy had greater reality distortion markers. And then people in the other game that were able to predict correctly with some more confidence the lake choice also reported low suspiciousness levels. Now, this was just an initial marker we did with a subgroup of people, but they weren't also presenting with psychosis a lot. And so that's why you see all of these flow effects. And so the next step that we want to do with this work is to go ahead and deploy this with a more symptomatic sample, and then also see how well this lines up with like the clinical care pathways that people also experience. And that's our work, basically. My name is Orth, and this work was done with the Center for Addiction and Mental Health at University of Toronto. Cheers.
Thank you so much. And we will move on to presenter number 5.
Does everyone see that? Wonderful, I'll get started. Hello, everyone. My name is Cal, and I'm here to present the poster, Building Interpersonal Trust and Resilience for Frontline Service Providers Through SIGBI. Frontline service providers are crucial for disaster response. However, the conditions they work in pose significant mental health challenges. Most interventions for providers focus solely on individual wellness and fail to capture team-based aspects such as supervisor-employee relationships. One platform gauging team-level factors is SIGBI, a tech-driven check-in tool delivered by the Hawaii Office of Wellness and Resilience following the 2023 Maui wildfires. Our first research question examined pre-implementation resilience and supervisor-employee interpersonal trust, while our second question explores whether these baseline measures correlate with well-being data collected during the SIGBI pilot period. Due to a lack of post-implementation survey completion, our team adjusted by comparing pre-implementation baseline results to SIGBI wellness data collected during the 3-month pilot. For our first finding, the key baseline construct table reveals that frontline providers reported high PR6 tenacity, which encompasses persistence, vision, which captures long-term purpose, and ITS affective and cognitive, which demonstrates rational and emotional trust with supervisors. Furthermore, the baseline subscale to subscale matrix shows that baseline trust with supervisors was negatively associated with lower physical well-being and PR6 momentum, which measures one's openness to new challenges. For our second finding, the wellness and PR6 correlation matrix displays that baseline tenacity was positively correlated with SIGBI well-being data throughout all 3 months. Our findings indicate that frontline workers have strong levels of purpose, perseverance, and trust with supervisors. Furthermore, this trust may be crucially linked to the employee's openness to new challenges and perhaps even physical health. Additionally, we believe that persistence may be a key determinant on whether they can maintain wellness in the wake of a disaster response. Future studies should investigate the connection between readiness for new challenges and physical health in relation to supervisor-employee trust, as well as examine the relationship between persistence and well-being in frontline providers. Thank you.
Fabulous, thank you. And we'll move on to presenter number 6. And remember to add those questions to the chat as things come up for you.
All right, can everyone see my screen okay? Great. Hi everyone, my name is Emily Hirsch. I'm a doctoral student at UMass Boston. Today I'll be sharing findings from an evaluation of MentorPro, which is a technology-enhanced mentoring platform for college students. Before I begin, I want to note that Dr. Rhodes is a MentorPro co-founder and 2 of our co-authors contract with MentorPro. College students, especially those from marginalized backgrounds, face significant mental health and academic challenges and often struggle to access help. Peer mentoring programs offer a promising first line of support, but they can be difficult to scale. Online tools can help mentors deliver targeted, just-in-time services, improving the reach and impact of these programs. Our team developed MentorPro, an online platform that connects college students with trained peer mentors. Features include secure messaging, check-ins where students rate challenges across key domains like well-being and academics, and campus-specific resources. We evaluated MentorPro during the 2023-2024 academic year, which was implemented within a peer mentoring program and academic learning community open to all incoming first-year students in the College of Liberal Arts. MentorPro was offered as an optional support tool to all students in the program. Our sample included 137 first-year students and was predominantly female, 1/3 identified as white and just over a quarter as Hispanic. We examined the associations between students' academic outcomes, one-year college retention, and engagement with MentorPro. Engagement was defined as the number of messages sent between mentees and mentors and the number of check-ins completed during the academic year. 55.5% of students logged into MentorPro at least once. Students with lower GPAs and fewer total credits checked in more often. Additionally, the number of messages exchanged significantly predicted one-year retention. For every additional message sent, the odds of retention increased by about 2.8%, even after controlling for demographic and academic factors. These findings suggest that students experiencing academic challenges may be more likely to seek support through MentorPro. Online mentoring platforms can help strengthen peer relationships, support college persistence, identify early student challenges, and enable mentors to provide personalized support at scale. Thank you so much for your attention.
Thank you. And we will move on to presenter number 7.
Can everyone see my screen? Okay. Hi, my name is Anushree Jagtap, and I'm a PGY1 psychiatry resident at Central Michigan University in Saginaw, Michigan. I have no conflicts of interest or disclosures today. Today, I'll be presenting our study, Telehealth Needs and Readiness Assessment of Behavioral Health Providers. This study was conducted during the COVID-19 pandemic when health precautions and social distancing significantly increased the demand for telehealth. Our goal was to better understand how behavioral health providers in Michigan navigated this transition, including what barriers they faced and how telehealth delivery could be improved moving forward. We surveyed 94 providers, including 81 mental health providers and 13 physicians across 26 counties in Michigan, as part of the CDC-funded PRISM initiative, Preventing Suicide in Michigan Men. A 24-question survey was distributed to directors of federally qualified health centers, community mental health organizations, hospitals, and other community mental health groups. While telehealth played a vital role in maintaining access to our care, our findings revealed several challenges that limited its effectiveness. 63% of providers had no prior telehealth training, and nearly half felt they could not deliver care as effectively online. Common issues included reimbursement policies, lack of simulation or documentation training, and unclear virtual care guidelines. The most frequently reported barrier was clients' limited technology skills.
50% of providers said virtual visits were shorter than in-person visits, yet 32% saw better attendance online. Despite these hurdles, 100% of respondents recognized telehealth as important during COVID, and the majority plan to continue using it in their future practice. It is worth noting that the study was limited by geographic scope and sample size, which may affect the generalizability of its findings. In summary, while telehealth is a viable model for behavioral health care, its long-term success depends on targeted support, including training for providers, tech assistance for patients, and clear guidelines for virtual best practices. Thank you.
Terrific, thank you. And finally, we will have presenter number 8, and then we will turn to questions from the audience.
Can everyone see my screen? Fantastic. Hi, welcome to my talk on Innovate to Elevate, Integrating Technology for Greater Access, Engagement, and Impact. My name is Stephanie Coakley. I bring you greetings from Philadelphia, the city of brotherly love and sisterly affection. My work is at the intersection of elite sport and mental health. I serve as a Senior Associate Athletic Director for Mental Health, Wellness, and Performance at Temple University. In this role, and the team and I serve about 550 student athletes across 19 sports. My appreciation for technology and how it can be used to help others is what guides my work and what brings me here today. In the mental health space, I actually began using biofeedback with children living with sickle cell disease to help them manage their pain prior to this role. That foundation shaped how I support student athletes through TUL. At TUL, we use tools like Blueprint, a HIPAA-compliant measurement-based care platform that tracks engagement and outcomes. And we have also explored the use of solutions like Trace Data Science, which uses AI to detect anxiety and depression through speech patterns, allowing for earlier and smarter intervention. Another use case of Blueprint is that we use it to administer all of our annual pre-participation mental health screenings. In the wellness space, our goal is to be proactive. I always say nothing has to be wrong with you to want to be better. Tools like Headspace, WellTrack Boost, and Whoop help student athletes learn mindfulness, manage stress, improve sleep, and self-awareness. We are currently piloting a platform called Journey. It's a mentor, and student athletes can get 24/7 support for life stressors such as NIL and the transfer portal anytime they need it. On the mental performance side, we use technology such as M-Wave to train coherence and Mendy, the Mendy headset, to strengthen attention and decision-making. All of this ties to what I call the 4 A's: awareness, access, advocacy, and advancement. At TUL, we've built a scalable student-athlete-centered model for wellness services, but technology alone cannot be the solution. We must lead with ethics, empathy, and equity. Technology isn't just changing mental health, it's empowering student athletes and others to take ownership of their well-being. That's the future that we're building together. Thank you.
Thank you. Audience members, so we do have time. Thank you to all the presenters for keeping on time so well. We have plenty of time for questions, so appreciate that. So to open up to questions from the audience. It can be a specific question about, for more detail on a particular study, or, a question that was raised for you across what you saw today. So feel free to unmute yourself or put something in the chat.
I have a question for Emily. I was curious whether with the mentorship program, well, two questions. So first of all, was it pure text-based, or was it also like video calls? Might have missed it.
Yes, it was purely text-based on the app, but since it was embedded within a larger peer mentoring program, there was also an in-person component as well, so folks could meet in person as well as communicate on the app via text.
Okay. And did you track that and like look for any differences in terms of in-person versus not?
You know what? We didn't look at that. I think that would be really interesting for a future study.
Okay. Cool.
I'm curious about, for those of you who did work in student settings, and I missed the first section because I've been bouncing around between things, but for those of you who did work in student settings, I'm wondering, like, what have you learned about how to engage students? I mean, one of the things that we've done and we've saw in the past is this, that students are so overwhelmed with messages and with all kinds of things. It's hard to break through in that environment. So, like, if you're trying to set up a really a comprehensive system in a higher ed setting, just wonder if you can just sort of talk about your learnings, what worked, what didn't, what you do differently.
I can go ahead and just jump in. We have a peer student athlete group who are like somewhat like our boots on the ground. And so they take the message out to their peers, and we know that peers have more credibility with their peers. And so when we want to promote resources, any of this technology, that's one vehicle that we use. So our peer student athlete group, and we also use a lot of social media. And so we pump messages through Instagram. Check this out. We're having this. Try this. Come do this.
Thank you.
Yeah, I can also, oh, sorry.
Go ahead.
I can also jump in. So I think something that's been helpful is having MentorPro as a hub where students can access university resources, access different apps, text and contact their mentors directly through that app instead of sending them out to all of these different places. I think another thing that we noticed was engagement was a lot higher in the fall semester. So students are coming in with more questions and more challenges at the beginning. And so really kind of using that sort of like interest and engagement and kind of capitalizing on that at the beginning of the semester because it really dwindled at the end. So we're thinking about how to maintain engagement throughout the year as well.
My poster wasn't about students, but I'm myself still an undergraduate, and at least from the people that I talk to and myself, two of the biggest things is first having like genuine word of mouth advocates on campus, because I think they're getting so bombarded with text messages and all these other things that like the most meaningful thing is a friend going, hey, I checked this out and it worked for me. And the second thing, I think the most important thing is when they reach out and when they call, have someone on the line. I can tell you firsthand from people that have talked to me, the most disheartening thing is when you finally build up the courage to call like some sort of mental health support and you're put on hold for 15 minutes. Or you have to like, reschedule somewhere else. And there's not much priority, I guess.
So I think there's a question buried in here, but an observation I had across what you're is it seems to me that all three of you who just spoke about a piece of it actually all referenced actual live human interaction in some way, shape, or form, right? And so I'm curious about, and the technology in some ways augmenting that, right? So there's human in-person interaction in some way, shape, or form, whether it's to get you connected to the technology or as an additional tool, and the technology is supporting that relationship. And so I'm curious from all of the presenters, how you're thinking about technology as augmentation to in-person relationships. And so the technology is a tool to help support greater engagement with. So for example, in some of the telehealth work, is it replacing all the in-person, or is it being used in conjunction with less occasional or with more occasional in-person, right? Versus where is the technology actually either replacing or serving as when there isn't an in-person option available. I don't know if that makes sense, but augmentation versus in and of itself technology. So I would love to hear from any of you about how you're thinking about that and the work you're doing with the tools.
I can start. So I think we're really thinking about the tool as supporting an in-person mentoring relationship and really augmenting that. And so we, encourage mentees and mentors to meet in person outside of the app. And I also think that the tool actually kind of helps facilitate that relationship because, for example, if a student says they're really struggling with academics, that really provides context for the relationship. So then in the relationship, they can build on things that they, have already talked about in the app.
I think it really depends on what your goal is for the tool that you're using. I use a variety of tools, and some of the tools are more, I promote those tools to meet the student athlete where they're at. So they may not want to come in between 9 and 5, and I'm only here between 9 and 5, but especially the mentor, like our Journey AI. That's for 24/7, 365. When I have a question about my sport career transition, or when I have a question about, like, I'm thinking about transferring, but I just transferred, like, those questions come up on their time. And so I think that tool is probably going to be better when they have more autonomy related to the tool. But like Blueprint, I use that in the session when they're here with me. If, for example, if they haven't completed their assessments for the week, we'll use it in session because that data is important for treatment planning. And so more guided by me as a clinician. And then certainly some of the other tools are to build skills. So they are like, here you go a little bit, but now go and try that without the tool. So it just depends, I think, on what you're using the solution for, what you want to accomplish.
Thanks. Go ahead, Samara, and then Paz, I saw you put a question in as well. We'll get to that right
Thank
after.
you. Yeah, so for us at Kooth, the intervention I shared today is a waitlist support intervention. So it's an integrated pathway where we try to take pressure off the NHS service. And what we've seen with that is that some young people who use the intervention then do not see a need for further face-to-face intervention, and some people would see a need. So I think we're trying to rethink how we measure success. As a digital intervention, currently we're seeing success as when people no longer feel a need for that intervention, the face-to-face one. However, after this pilot, it's reshifted our thinking a little bit, and now we're recognizing that some people might need both support systems or might have a need for that in-person face-to-face. So I think it's really about, giving people choice. And I think digital mental health support systems have a very, very useful and important place in the market. But I don't think they're necessarily the answer for everything and everyone. And I think that, just recognizing where they are the right fit is really crucial. Thanks.
Thank you. And I can see we have 3 questions in the chat. So maybe I'll go through, and if you want to unmute yourself and ask your question. Emily, do you want to go ahead and ask your question?
Sure. I was wondering if you could talk a little bit about what you think are some approaches that we can use to increase both client and provider digital literacy and comfort using these digital tools.
Yeah, it's a really good question. I know a lot of people had that question, especially when the pandemic happened too, because telehealth is so new. I think like implementing training modules or having simulation modules, even something similar online, like a link you can go to that kind of points out expectations of the telehealth visit versus what you'd get in an in-person visit. Telehealth just has different rules that you have to follow. There's nuances that you have to kind of keep in mind, like making sure the lighting is right, making sure the client on the other side has privacy, making sure there's a backup plan or a safety plan in place in case things go south. And, as a provider, the physician, you cannot be there physically. So these are all things that should probably be set up ahead of time, and being included in a training module could maybe help give more understanding to the client and the provider.
Thank you. Paz, do you want to ask your question?
Yes, thank you. So for Orlu, I hope I'm pronouncing it as I should. Can you hear me? Okay, so
I can hear you okay.
yeah, thank you. So I was wondering about reaction times. I might have missed, but I saw you checked performance, and I was wondering if reaction times alone could predict some of the symptoms you were talking about.
Yeah, so it was one of the things that we explored for a separate task, which I didn't include here. But in this case, well, when we deployed this task, one of the things we were looking at specifically was the decision making, as opposed to how long it took them to come to that decision itself. In the next run of the deployments, one of the things we want to do is then look specifically at those reaction time values and see if that works. Since we didn't necessarily tell them they have to respond in a short time frame, so people weren't asked to kind of finish the task as quickly as possible, but as opposed to just take the time and process it properly. So yeah.
I see. Thank you.
Great. Cal, do you want to ask your question?
Yeah. It's for Stephanie. I was just curious how you measured the improvements in awareness, access, advocacy, and advancement.
Well, that's a good question. I'm a clinician and I don't do a ton of research, even though I'm currently like working on 2 studies right now, one for sustained attention and decision-making using the Mendy headset for performance. And the other one is the pilot, like we mentioned about Journey AI. But anecdotally, our student athletes, if you are tracking your symptoms of anxiety and depression, and also doing interventions that are associated with Blueprint. Blueprint not only has assessments, but they have interventions and they have different other tracking strategies. Student athletes overwhelmingly are more aware of triggers for their anxiety, triggers for their depression, and then they are able to regulate and take the specific actions. So, I mean, just anecdotally, I know student athletes are more aware because they are tracking the symptoms in real time and then gaining good insight. Additionally, with the advocacy, our group of student athletes is roughly about 50 to 60 student athletes out of 550 who generally show up. And I've done lots of programming in this space. And if we get 10, that's a pretty good number. So when we get numbers like we have mental health advocates showing up in 40s and 50s and 60s for meetings once a month, like that just tells me like we do have a lot of people, student athletes, who care about this topic and who not just care about it for themselves, but care about it for their community. So they're constantly out there advocating, and every student athlete here at Temple has access to everything that I talked about. So there's a lot of access here. And we've kind of eliminated some of the barriers to cost. That's why we can't use everything that I see, but what I examine and deem appropriate and we can afford, because cost is always an issue, we provide access.
Thank you.
You're welcome.
Yeah, great. And Emily, it looked like you had another question. I actually was wondering about that also. So excited that you asked that. If you want to go ahead and ask.
Yeah, sure. I was wondering what advice you have for researchers looking to incorporate gamification or design games for their studies, and also wondering what challenges did you encounter and how did you address them?
Yeah, I'm guessing that's for me, so I'm gonna go ahead and talk towards that. I think one of the things about these games was they first started out as basic cognitive tasks. And so it would be trying to make them extension of already established cognitive tasks that you have some theory behind. And then the gamification parts now start to look at like context in which they can be displayed. So if I take the first advice taking task, what the original version was just like a thing with 2 different cards. So it was like a red card and a green card think of them as square boxes, and people chose one or the other and got points. And then in other cases, I think taking inspiration from like games that we see online that people play, kind of like fun themes around them. So, you know, you're going through a jungle, it reminds you of like this Temple Run game, if you remember that one that people played. Or the fish task game reminding you of like, you know, just other kind of playful themes, but behind the scenes, the core theory is still what you're measuring in the context of the values that you're extracting. So I think that's one thing to keep in mind a lot. When it comes to implementation, the good thing about technology these days is that you can take advantage of these AI tools a lot. There's this program called JS-Psych, which allows for experimental delivery of online cognitive assessments. And essentially, you can have your cognitive experiment that you want to test for using something like that. And then you could post on ChatGPT, like, hey, give me a JS-Psych experiment. I can do this or do that. The only other thing to keep in mind, of course, is those variables and what you're extracting. And so you want to be logging, you know, specifically as the decisions are being made, and then afterwards doing your analysis to see that they align together. But in summary, it's more so taking inspiration from already like established tests that people do and figuring out how to make them digitally available. And then the next part on top of it is how can you make it more relatable to the context or group of people that you're deploying it with. With these games, for example, the end goal was to deploy this within help-seeking youth. And so you want things, and they're aged between like 12 to 24. So you want things that are more kind of enticing or attractive towards them. If you're dealing with an older population, I think it might be a bit different. So culturally relevant things, we had youth engagement advisors kind of give feedback on the games too, to make sure that they weren't too, that they were like accepted basically by the people that are going to use them. So yeah.
Thank you so
And
much.
yes, the program is called JS-Psych. I'm just gonna put type it in here and then find a link to the website and drop it in the chat also.
Great, thank you. And I see that there is a question for Paz in the chat. I think she had to jump off due to an emergency where she is. So I'll pause for one moment in case she's actually there off screen, but I'm pretty sure she had to run. Yeah, okay. 5 minutes left. Any final questions for folks that people or share or thought across them?
I just want to point out, like, I think the gamification is attractive to certain populations. And when I worked a long time ago with children with sickle cell disease, on a HEMONC unit, we used video games back then for them to like, you're playing video games, you're calmer, your body's not stressed and tense, so that pain is not as evident, but also like they were also like blasting cancer cells or like attacking like blood clots in your, so with that also imagery, which that's in my wheelhouse of sports psych, imagery. So you're doing a couple of things. You're alleviating stress in the body, and you're creating optimistic and powerfully healing images for our young people who are going through not arguably very difficult times. And so I just found lots of that, I kind of got into my tech interest when I worked with that population. So the gamification of interventions is quite attractive.
Yeah, I think that's exactly, I mean, I think particularly for anyone who works with youth, right? You really see that as an engagement tool, right? To keep them active and engaged. So in the last couple minutes, I would love to build on the question that actually was for Paz about AI, and curious, how you all are thinking about the ways in which you may, if you're not already using AI in your work, or both the promises and maybe the challenges or concerns you may have about it for the work that you have.
As a clinician, AI generated or assisted therapeutic notes, treatment plan. I mean, the decrease in labor and hours after work and after sessions, and which ultimately oftentimes for therapists lead to burnout, has improved. So I mean, I can't say enough about that aspect of it. I mean, I have lots of great things to say about utilizing AI in the work that I do across all the levels, but I think the biggest for me as a clinician is the use of the notes. And then being able to just like, instead of start from scratch, like you're just refining and making a note a little bit more detailed. But that's a different story than writing a whole treatment note. So I appreciate it greatly.
Connecting it back to your original question of like online being augmenter versus replacing, at least in therapeutic interactions with patients, I really hope, and it might not be so, but I really hope it only takes an augmenting role. I think you can't take away the human interaction or aspect of therapy. But I think there's also a lot of other ways on the more administrative side, and for like the notes, like you said, with the notes, where it's very, very helpful and it allows therapists to actually spend more time thinking about the patient and thinking, putting in that sort of work. So.
Well, I think also though, it's really, for patient-facing tools, I think different people want different things. And so like we, did a lot of, development of a patient-facing tool that, did randomized controlled trials, and it was, supported by a coach. And, when we rolled it out in real world development with real world patients, in several settings, in all of the settings, about half never connected with a coach, like in spite of repeatedly bugging them. So, there are a lot of people out there that are experiencing a lot of pain and they don't want to talk to somebody for whatever reason, but they do want help. So I think, technology can assist therapists in ways that you're talking about. It can provide, low, treatment with coaching. And for some people, they just don't want to talk to another human being, and it can be helpful. Those people did get better. So it's I think we have to meet people where they are.
I will add, in the field of psychiatry, I know we prefer seeing patients in person, especially on that first visit when you do the initial evaluation, just because there's so many nuances in that physical interaction that you just can't get over a line. So I know like telehealth is something that we definitely don't want to replace in-person visits, and we would definitely use it as an adjunct for those who live farther away or have difficulty commuting, but we definitely want to preserve that inpatient component. And then that's where the in-person component, and I think that's where AI could also help too, or those patients who are less acute, who still have that insight, able to function throughout their daily life and just need that extra boost of therapy. They could maybe utilize AI if we continue to develop that.
Great. Well, thank you all. We have reached the end of this session. So I think you have a 10-minute break now. And thank you all. Thanks to all the presenters. It was really wonderful to hear about all the exciting work you're doing. And we hope you enjoy the last afternoon of the conference. Take care, everyone.